I am Councillor Lucy Knight, Chair of the Committee, and I will be chairing tonight's meeting. The meeting is being streamed live on YouTube, and members of the public and the media are welcome to watch the meeting remotely and listen to the discussions taking place. Now, I'd like to welcome you all to Committee Room 1 at Kensington Town Hall and ask that before we proceed with the meeting, can everyone present please ensure your phones are switched off or on silent. Thank you. And we will now observe 72 seconds silence to remember those who lost their lives in the Grenfell tragedy. Thank you. Starting with apologies for absence. Apologies for absence being received from Councillor Josh Rendell, lead member of Alexandria Care Public Health, and Gina Ashton, the co-opted Health Watch member. Maria Charlie, Borough Manager for Health Watch RBKC, and Minna Borjonen, Health Watch Advisory Board Chair, are here to represent Health Watch instead. Declarations of interest. Does any member have any interest to declare? We've also just to note that Roberto is meant to be coming for this. Minutes from the previous meeting. The minutes of the meetings held on the 6th of November 2025 and 26th of November 2025 have been submitted for confirmation that the committee agreed that they can be signed as correct record.
Agree.
Thanks. And moving on to the piece of paper, which is Adult Autism Services. This report sets out an update to members of autism services in the borough, representatives from Central London Community Healthcare NHS Trust, who are commissioned. Providers have been invited to present the report and answer any questions. Would you like to come up? We've got Dr. Catherine Chung, Service Lead, Central London Adult Autism Services, Mark Mbogo, Deputy Director of Operations in North West London Division, and Phil Williams, Service Manager from Hammersmith, Westminster, Kensington, Chelsea, Learning Disability Students. And then from RBKC, we have Seth Mills, who is the Vice Director of Learning Disability Students. Provider services. Just want to ask who wants to enter the report.
I'll do a quick intro and pass over to my NHS colleagues. Just to say thank you, members of the just to advise that colleagues here produced the NHS to advise about autism services in RBKC, focusing primarily on diagnostics work, case management, practice and clinical work as well, challenges and future challenges that they perceive to be coming forward, and also about the waiting times and challenges within the waiting time and what they're going to do to improve those. I'd just like to hand over to my NHS colleagues now. The paper, and I invite members to scrutinise the papers and the information therein.
Hi, my name is Catherine. I'm a clinical psychologist by background. I'm joined by my colleagues today to talk about our service and the work we do. Can everyone hear me okay? Yes. Sometimes I do talk very quickly, so feel free to slow me down. I remember joining the service in 2017 as a qualified. And at that time, we're receiving fewer than 100 referrals. And today we're looking at 1,500 referrals each year. The service size hasn't changed massively. We are relatively a very small team in adult autism diagnostic assessments. So there is a real significant gap between the demand and our capacity. I recognize that. I think we all recognize that services are never perfect. So we really value this opportunity to understand how our work is coming across, what the gaps are, what perhaps suggestions and recommendations might be, and how we can improve our service. I think as a service, we've been very fortunate. Management has always been incredibly supportive, and that has given us the freedom to do a lot of innovative work. As you would have seen from the paper, we have come up with various different pathways and initiatives to help improve access, especially for the most vulnerable groups. Clients who might be rough sleeping, clients with significant mental health needs, clients who have repeated crisis episodes. So our work really tries to think about how to reduce health inequalities and reach out to those who are most vulnerable and not waiting for people to reach us. So we try to take a very neuroaffirmative approach. We're very person-centered. We try to be as strength-based as possible, but also recognizing that our clients do face a multitude of challenges, and often services are not perfectly designed to meet all the multitude of needs they present. So we're always learning in how we can support our client group. Perhaps I'll wait for questions before sharing more information. I know there is a huge curiosity all the time about waiting times. Our waiting time does vary depending on the person's level of needs, the urgency, the risks. So it varies between less than 1 month to about 14 months at the moment, but more than happy to talk about that.
Does anyone else want to add anything? Should we go straight to question?
First questions, I think.
Okay. Thank you for the paper, and I think it's very clear the sharp rises you are seeing in terms of cases. And I wanted to start by just asking why you think that is, and are we fully prepared given the staffing you've noted within the report? And I think you said you almost need to double your staff to meet the needs of what you're currently needing. So looking forward to the next 18 months, year, what are your plans in terms of this? Doubling staff sounds quite drastic. I think there was one position of that you're looking to recruit. So just to hear an update on that would be great.
I think it's a very positive thing that actually the demand is rising, because for a very long time there are a lot of undiagnosed adults who are autistic. I think if you're looking at 20, 30 years ago, autism was understood in such a narrow way. So many people who are struggling silently are not being picked up or not being referred. And even when they go and ask for an assessment, health professionals will be thinking, oh, but you have a family, you're married, how is it possible that you're autistic? So I think in the recent years, there is so much greater understanding about what autism can look like across the population. So we're seeing a lot more people who have what I call more subtle, nuanced autistic traits, who are finally coming to seek an assessment. I think that for a very long time, there was such a harmful belief that autistic individuals could possibly be married or holding down a job or be functioning independently in the community. And that is not true. I think people can have all of that and still have a lot of internal struggles warranting mental health support and be autistic. I think the shift from understanding autism as a disability and a deficit to understanding it as a difference in a neurodivergent condition also removed a lot of the stigma, and it encouraged people to seek help. So I think if we look at the data, for instance, women were significantly underdiagnosed. I think we also noticed that men who have very good verbal abilities and are socially motivated are also significantly missed. People who live with gender dysphoria or struggle with a gender identity, often their gender identity would overshadow them being possibly neurodivergent. There are also a lot of misdiagnoses in the past where people might be autistic, but they have been diagnosed with personality disorders. So I think in the recent years, our improved understanding, a more nuanced understanding of autism and what that actually means and what it looks like have significant has significantly improved the rates of referrals. In terms of capacity, I think realistically, there are only so many assessments each clinician can complete each month. We can come up with, various innovative ways. So our service takes a very flexible assessment model. So traditionally, an autism assessment might take, let's say, 5 to 6 sessions. For us, we take a just enough approach. So if there's enough information, we're not going to pain the person and keep asking them questions to prove a point. We'll say, we meet with them. It's very clear from the meeting that they're autistic. We'll give the feedback on the day. So the assessment itself can be very, very quick. But sometimes what requires a lot of input and follow-up is not the diagnostic decision, but the follow-up, the aftercare, making sure that people are not lost in the system, making sure that referrals to other services are being accepted. So even though our service is primarily commissioned to be a diagnostic service, actually that is not all of our work. A lot of our work is care coordination, care navigation, follow-up support. It's the work that we sometimes have to secretly do because it's not in our commission brief, but it's essential, and we can't deliver an autism diagnostic service without providing this aftercare. So that, again, of course, if a chunk of the week is being dedicated to consultation or follow-ups, then of course it reduces our capacity for diagnostic assessment. So I think ultimately we do need more investment in adult autism services if we want to meet the current demand or the future demand.
Great.
And do you have, just in terms of those 2 points on staffing or the recruitment of that position that you noted in the paper, is there any updates on that?
Not presently. We're in negotiations with the ICB.
Yeah, I think one thing to mention is I think the picture that we have presented here is better than the reality in terms of the trust. We were lucky we had some understanding within the trust. And we got some money to manage about 100 assessments. So if we didn't have that money within the trust, within COCH, the picture I think would be worse in terms of the budget that we have. Of course, we have to do some efficiencies and we have to look at innovative ways of working. But actually, if we didn't have that investment from the trust, which is a one-off, I think the number of people waiting would be more. Mm-hmm. One of the things we're doing, if you look at the paper, I think we talked about DNA, so people who don't attend, ranges between 2 to 10%. So if we reduced that 10% to the trust target is about 6%, then we would see more people. So there are some things we're doing within the trust to improve our performance. But actually, I think as Catherine has mentioned, I think the capacity is an issue because of the rising demand.
And one quick question just to add to that is, if you're under this demand, are a portion of referrals being outsourced, and if so, by whom, and how are we sort of understanding the quality of the standards if everyone's saying about?
Such a good question, and it's one that we constantly think about. So we are very careful with choosing our provider. Our current provider has been working with us for some time, and they're quite reliable. They're very good at coming to us if there are any queries or if a case might not be suitable for them to see because they need that wraparound support. We are also very selective in terms of whom we outsource, whom we send down the outsourcing pathway. So, for instance, we see so many clients with very complex mental health and adult social care needs, and those clients that we would never, if we have that knowledge, we would never send them down the outsourcing pathway because that pathway requires a level of independence, being able to manage, not having significant mental health needs or social care needs. So if someone is already known to mental health services, they have repeated crisis episodes, or they might have past inpatient admissions and can be at risk of another admission, we will never send them to the outsourcing because assuming them means that we can, during the entire process, whilst they're on a waiting list, we can work closely with social care or mental health colleagues to make sure that they are safe So this wraparound support for us is quite important.
Just to add to that point as well, the service teams who are outsourced are given a choice about whether they wish to be outsourced or whether they would be with us. So that I'm ever the psychologist in the team, so I haven't got yet.
Just continue that, really. Thank you very much for the paper. And in a way, reading it, you're sort of victims of your own success, aren't you? That you've improved what you do so it gets more people. And again, that's the path I want to look at, the future. If you're saying you need more investment, do you think the investment's going to be there? Because we have a picture of a lot of investment reducing across the NHS, local government, and all the agencies involved. And if you're struggling to keep up with the demand now, if you improve your services to cope with that demand, you're just going to be creating more a bigger need, a bigger demand, and then that ripples, doesn't it, to who provides then the services after you've diagnosed these people. So it's really just a whole picture going forward. The report's great, but it just paints a picture of we're not coping where we are now. If you get better, there's going to be a knock-on effect, isn't there? A lot of questions, Sarah.
No, I think it's a really good point, and I'm also thinking about how autism is a relatively young field compared to so many other conditions that have specialist services set up. I think, for instance, personality disorder is a very well understood for all its faults, whether or not we even believe in the construct of personality disorder, but it is a more robust model that they have tested out. Similarly, with general mental health services, it is a very well-tested model, whereas autism, especially for adults, when it was first set up, it was thought that maybe a unidiscipline service would be sufficient. Whereas if someone were to be diagnosed as children, they would be seen by a pediatrician, they would be seen by a clinical psychologist, an OT and SOT, all of that. So I suppose there is a lot of learning we are doing, both systemically and systematically, and nationally, as well as a service. So I think you're absolutely right, because often we work so closely with our mental health colleagues and adult social care colleagues, and third sector as well. And even the confidence of professionals working with an autistic client really varies across the board. Some professionals will be so fluent in knowing how to work with someone neurodivergent, and some clinicians would be quite uncertain, not because they're not skilled enough, just because they haven't had as much exposure. So I think we're in this awkward time where people are learning, and perhaps even as services and commissioners, we're learning. So I think it's a really...
And the investment, Mark mentioned a one-off investment,
yes.
But what about as the service grows, is the investment going to grow, or do you have any sense of that?
Question from my CV, I think.
Yeah, but I think one thing we are looking at is the referral process. So when people are referred to the service, because we do acknowledge we cannot see everyone. So could some of these referrals being seen either by the GP or actually get services from the voluntary sector, so that not everybody comes to the autism service, because we wouldn't be able to cope with everyone. And I think that's a really good area, because if we don't want to reject people, obviously, because then people get very frustrated, but just work with referrers and mental health to make sure actually is this the right pathway to refer the services, or whether they could be seen somewhere else before waiting for 40 weeks for an assessment.
Thank you.
Thank you for this report. And I just want to talk about the 18 weeks ambition.
Yes.
Is there an agreed local ambition or trajectory towards an 18-week standard for adult autism diagnosis? And what would it take to deliver it?
Really good question. It would be ideal if there is an 18-week wait only that we're able to meet the targets. On the plus side, I would say is whoever comes through our service, if the referral is accepted, they do get a well-being check-in within 2 weeks. So we have a very robust and solid process of ensuring that if someone is waiting, they're okay to wait well. They can wait well, and they're okay to wait. And even when we're waiting, they're never just idly waiting. We're reviewing the waiting list. So when a referral comes in, the qualified clinicians would triage, and then we would categorize the referral based on the information we have. So we would think like, is this person quite at risk and they need to be seen sooner? So we would put that in priority 3. If this person is waiting well, they're quite motivated, they can look after themselves, they have good access to support, they're quite motivated and proactive in reaching out for support, and they're relatively stable with no mental health or social care needs, that would be rated as a 1, which is really rare. I would say that's less than 10% of our referrals. And then other people would have mental health needs, social care needs, but at a stable place or being supported. So each month we would review the client groups who are rated 3, review the clinical notes to see if there are any changes in presentation. We would reach out and call them for a well-being check to say, just want to let you know you're still with us. Are things okay? Are you being supported? And making sure that they're accessing support if needed. And we also have waiting well initiatives where people can come to us and reach out to us if they need to talk about the reasons that might have made them come for an autism assessment in the first place. So I would say for the full formal diagnostic assessment, at the moment, we're not at the place where we can have an 18-week achievement. However, and this is not to be blowing our own trumpets and paint a very rosy picture. I think for us, it's also just a very essential part of the work that we have to do to mitigate risk. So for us, that this process is a non-negotiable. So what we can guarantee is that we would have spoken to everyone waiting before 18 weeks. And they would be able to put a name to the service, a voice to the service. That's what we can promise.
We operate an advice clinic as well, so if people have kind of an urgent concern that's related to that autism. So how do I manage this particular thing that's happening in my life, in my experience? They can book into that advice clinic while they're on the waiting list, and we can provide that kind of advice and signposting. And I guess when we prioritise as well, those priorities and categories can change if someone's circumstances change on the waiting list. So it's very fluid in terms of how long people wait.
Yeah. What is the question? I just want to ask one more question, Chair. And beyond case studies, how are outcomes of post-diagnostic support being measured? I mean, how do you measure it, particularly those with mental health and employment and our reduced service use elsewhere to the system? How do you measure?
Really good question. And I'm almost thinking, what is a measurement? What would we be trying to measure? Because the post-diagnostic support aims at boosting somebody's understanding of their autism. It aims at helping someone to understand how their autism interacts with other psychosocial facets of their life. It might be skills building or coping strategies. So if someone has quite significant sensory needs, other strategies to put in place. If they find it hard to advocate for themselves, can we bring them some communication strategies? At the moment, there is not a post-diagnostic support measure that we typically use. So we very much rely on service users feedback. And I think because we take quite a person-centered approach, so some services would only provide groups. For us, we don't think it's a model that would work for our client group because most of them would not want to be in a group, and some of them are way too complex to find a group helpful. So we give people the choice of one-to-one or group, depending on what they want. Most post-diagnostic support is about 2 sessions. It's very, very short because the aim is helping people to access existing mainstream services. But there may be people where actually really understanding their autism would give so much better outcome in the long run, and we would see them for much longer. So we might see them 6 sessions, and sometimes we might even stay involved in the background, offering consultation to professionals, helping professionals to carry out our reasonable adjustments, recommendations. So at the moment, you're right, we don't, I guess I'm thinking about how in mental services, they can measure, say, this person started on GAT7 21, and then now they score a 7 on the questionnaire, so it's a significant difference. Unfortunately, we don't have that.
No, it's good, but it's a really good question, and
Yeah.
we'll certainly take that away.
Maybe we can have a Likert scale of satisfaction.
Yeah.
Thank you.
Yeah, I had a very similar question to two questions to Portia, because so if I understand correctly, it's not a disease, it's a condition. And as a result, and case in point, there is no medication, unlike, you know, ADHD or schizophrenia or depressions. All those examples were very interesting. And what came across quite clearly is the most severe examples are often, if not all the time, paired with actually some serious mental health disease. The other sets of examples were very much what you said, validation, which is not unimportant, but in terms of our responsibilities here as elected members with limited budget, it's perhaps less of a priority financially, because what we want to focus our budget is the safeguarding of vulnerable cases. So people who are at risk for themselves and risk for the community. And somebody who has coped all their adult life needs validation. But what I'm trying to sense here is, how can you prioritize your needs, because the money is not infinite? And whilst I would like to validate everyone in their feelings, including mine, and including my husband, who's definitely on the spectrum, I just think that realistically, you know, we do need some clear guidance from professionals about, you know, how do we make sure the most vulnerable cases are actually covered, where the money can go prior, you know. And that point you made, Portia, was very interesting, is how can we measure that? Because we really need to protect our most vulnerable cases. And yeah, and for me, this hasn't come across so clearly in the report. It was fascinating, but it left me with a lot of questions about where to put the cursor.
It's such a good question. You're right. We can't validate everyone. In an ideal world, I don't think we should even need an autism diagnosis, because, as you said,
it's a condition,
it's
right?
a condition.
Exactly. It's not a disease.
Yeah, and I think, unfortunately, I think if looking at the literature, a lot of people would say autism is a social justice condition, because people are being stigmatized, or their needs not being understood, or they're being forced to follow certain social conventions, and they are being disadvantaged, or they're expected to perform in a certain way that is not true to their nature, or not matching their preferences. Because if you look at the data for autism, it has a very high unemployment rates. It has very high mental health rates. Their autistic individuals are at greater risk of suicide than the average population. Definitely autism alone is not the issue. It's probably a function of negative social experiences that have led them to feel very bad about themselves and very bad about the world. It's very hard to know whether or not we should be validating everyone, because the person who is just needing validation now, if they don't have the diagnosis, they might also be prone to deterioration in the future. So, and I think it's a constant ethical battle for us, honestly, like, who should we see first? Because in an ideal world, we should see everyone who is autistic and in need of the label. So at the moment, I think this is why we have those prioritization pathways. So for instance, at the service lead, most of my caseload is for the mental health pathway. I see the clients who are on the inpatient, a referral come in, I'm there next week, working with the team to figure out whether or not this person A should even be seen for an autism assessment. It's about providing support, consultation, recommendations to the team, even if they're not autistic. Because I think one of the points that I want to pick up on from Mark is that there is a struggle between, do people need a diagnosis to access support, or actually they don't need a diagnosis and it can be needs basis. I think both are true. Sometimes a diagnosis opens doors. It provides a shortcut or shorthand for people who don't understand or know the person well to understand how to adapt the behaviors, to be less blaming, to be more compassionate, to be more patient. So there is real beauty in the diagnosis. But in an ideal world where everyone is person-centered, everyone is patient, not feeling stretched, then it doesn't matter, because we do see a lot of autistic people who function, who've been really well supported by services, by the family, without a diagnosis for decades. So yeah.
Yeah, I think it's a good point, and it's something we'll take away to discuss with our missionary colleagues, to look at the referral criteria and look at how, because you're absolutely right, in health or in local authority, there's no infinite amount of money, and we cannot see everyone. So we will need to look at the referral criteria and make that a bit tighter, so that we can serve the most vulnerable or patients who need it most. And the reason I say we work with our commissioners is because of managing expectations, both from the public and from referrers. Because once somebody gets through our doors, then it's very difficult to say, well, actually, we've waited 40 weeks or 18 weeks, we cannot see it more. So we'll take that action. And I actually think nationally, most of the autism services are struggling with their waiting list, and these national conversations about who should be accessing the service. So we'll take that action and look at how we can tighten our referral acceptance criteria. Also noting that if somebody needs a service, they need to go somewhere. So there might be an impact either on primary care or mental health, but we need to understand that. So we'll take that action.
Thank you, Chair, and thank you. It's fascinating discussion, and learning a lot about this. I guess my question was really a follow on to Stephanie's and Portia, which is about the post-diagnosis support that you talked about, and the follow-on care and the explanation. They feel it's not just me, the validation, the boosting the understanding, but then accessing the mainstream services, which you talked about. And so it's sort of, I guess what this implies is that because the demand for referrals is going up, and the demand for the mainstream services is also going up. And I just wondered whether you've got any sense of, what that looks like. Is that demand being met? I don't know. I mean, do you have any understanding of what happens when people move on from you to these other services?
Shall I start and those from me? I think that you're pointing out a really important aspect that is probably not just unique to autistic clients needing follow-up, because, for instance, I think mental health services are also very stretched. It will be something our CNWL colleagues will be able to comment on as they're provided for mental health services. I also, on the flip side, I also wonder whether or not, if the person hasn't been diagnosed with autism, they will still be accessing those services based on their needs. So I suppose if there is a longer wait, or if there is if services are being more selective with whom they see, then it's probably not just about the person being autistic or autism clients. And I think generally, as everyone has pointed out, budgets are getting tighter. Services are probably always finding it harder to achieve the ideal wait times.
I mean, the diagnosis presumably speeds up their ability to get access to those services, right?
I think it does and it doesn't, but what the diagnosis does do, I think, when they get into those services, it can really help in making sure that the person is accessing the appropriate care, or the care and therapeutic support that's kind of been tailored to having a diagnosis of autism. And we do know that those people do better within those services because they have that understanding. My hope is that it would speed up that access to mainstream services, but unfortunately that's not always the case. The pressures that are going on there as well.
I think sometimes it helps people to understand, oh gosh, maybe the person is very vulnerable because they're autistic, they might not be telling us X, Y, Z. and now understanding it through a lens of autism, the vulnerabilities and risks becomes a bit more pronounced or well understood. So in some cases, it does speed up service, it does speed up service access.
Thank you. The question I had was it related to the flexible dynamic assessment model, and just on the basis that obviously autism assessment can be quite an involved process, and what you think might have been lost with this approach, if anything, and whether this new model, I don't know how long it's been running for, as mentioned in the report, but whether there's been any kind of comparative evaluation of that, and yeah, just sort of curious to know as to what might potentially be lost. I appreciate the challenge of trying to meet everybody's needs. And then the other question was about sort of just access in general, and I think it's a positive thing, you could say, that referral rates are increasing. It isn't. But I was just wondering if there were if you had any concerns about any specific groups still being underrepresented, whether it's by location, ethnicity, any other kind of social determinants, and what you might be doing to try and engage those individuals.
I will start with the flexible dynamic assessment model first. I think that model, I guess I wonder if the query is about, if we were to see a person for shorter amounts of time, would we know less about them? And does that change the reliability or maybe the validity of the outcome, or more just about the amount of information?
I guess it's about the reliability and the whether you might be getting sort of an accurate enough picture, collateral information from family, school reports, which people might be looking at for, it's quite an involved process. So I was just curious to understand this kind of slimmer model of working, what that involved, and whether there was any kind of evaluation of it as well, if that approach has been validated.
Really good points. We haven't done a robust statistical evaluation. However, from a diagnostic perspective, because a lot of people won't qualify for that shorter assessment model, when we think about someone qualifying for that assessment model, usually it's someone, when I pick up the phone, it's already really obvious their communication style is very autistic.
Okay.
Or the moment they walk in the room, the autistic traits are very much.
Okay, so it's only a tiny proportion.
It's a very tiny proportion.
Okay, gotcha.
And usually it might be someone who is already very well known to services. So we might not be the one gathering that collateral or corroborating information, but that corroborating information would have been provided to us by services who have known the person for many, many years.
Okay.
So we're also relying on robust clinicians' information to support this diagnostic process. So it's almost like, and I think for us, this is also why we have the mental health pathway, because we find that if we were to see somebody whilst they're under the care of a service, it also lightens our load, because the person doesn't have to come to us and start from zero. We can have the conversation with the clinical psychologist, with their social worker, with their psychiatrist about, how has this person been? Have they always struggled socially in these aspects? Since you've met them 5 years ago, has things changed? You've tried all these different therapeutic interventions. Has it changed the aspects that we might associate with autism? And they might say, no, actually. So I think this is what enabled the flexible model, but it's definitely not for everyone. So once we haven't done that evaluation, which is something we definitely take away and think about how we can evaluate the validity of this approach. Anecdotally, no one has come back and say we don't agree with you. I think often if someone is not going to receive a diagnosis, we tend to be more cautious and make sure we complete all the steps.
Yes. Yeah.
It's usually in the case where we are really confident that someone is autistic that we might do a short
So it's a
assessment.
tiny proportion of the
Exactly.
referrals, and it's
Yeah.
people where you're fairly confident that it's going to be a yes.
Exactly.
It's not going to be like a false
Yeah.
negative.
Exactly.
And if during that process it turns out that the person is a bit more complex than when they present, we would then move them back onto the other pathway.
Exactly.
Thank you. I'm just going to ask a couple of questions, and I'm keen to bring in health.
Sorry, it's just about the second question. It's just about the certain groups that are, whether it was matched, the referrals were matching up to kind of local population demographics.
I think the last audit we did, it does map onto the demographics of the population.
It does. I mean, I think we know nationally there are certain groups which are underrepresented, but it feels as though in our borough, I think the demographics are matching at the moment.
I think some colleagues working in gender identity services would say that their client group remains underrepresented, or transgender individuals would also be underrepresented. I think there are a lot of times where the gender identity and the sexuality overshadows the neurodivergence. But I think these days there's a much better understanding that actually there is a much stronger correlation between the two.
Thank you. I was just going to ask on your escalation threshold, when someone is waiting, how are you deciding and able to monitor effectively when someone needs to be more urgently seen? I'm just going to quickly ask them so that we can move on to Health Watch. And then just in terms of so practical emotional support when someone is waiting for, say, up to 14 months, which I think is the worst case scenario, what does that look like in terms of services? And then I think there is 2 notes of, in terms of numbers. At one point it says 600 people waiting and elsewhere 650. So just to clarify on the figures on that front.
In terms of the escalation, I think first of all, I think we very much rely on what's available to us on the clinical records, and also the person reaching out to us or the professional network reaching out to us, because ultimately at the end of the day, we are not an urgent response service. Yeah. And if someone were to be at risk, we hope that they would address the risk first and then come to us. So usually it goes back to our initial prioritization process when we triage the referral, that we hope that the referral information is robust enough for us to do a robust triage. And then also we also do the regular file review to make sure people waiting are okay. So we've developed a risk mitigation SOC that lays out a very clear protocol for making sure that we are not missing people who might be at risk. And when we do the well-being check within the 2 weeks of accepting a referral, we also let people know that if anything changes in the circumstances or they think they should be seen sooner, then come and let us know. In terms of the number of people waiting, I'm so sorry. It might be the case where I have written the first figure, the 600, and then in the week the referrals came in, then they're just at one number. And I
can let you know.
That's the typo. But thank you so much for picking up on that one.
And then just in terms of the support that is on offer when not waiting.
So we have our advice clinic, which people are able to book into, and they speak to one of us. And we also, our assistant psychologists will do kind of harm reviews and things like that. We have our acceptance call that happens 2 weeks, and within 2 weeks of that referral being accepted, so we're in contact with people, reaching out at various points. But as Catherine said, we are sort of relying on people reaching out to us, just because we can't provide that sort of emergency response service.
Maria or Mila, do you want to add anything from Health Watch?
One question. Sorry, I don't want to like sort through it. But it would be useful for us from the Health Watch perspective to understand whether the referral or the triaging process prioritizes certain groups, and also how many people disengage with the process during the period in which they're waiting for a diagnosis.
Honestly, disengagement is quite low. So if anyone is moved, I think there's definitely fewer than 10 people each year who would withdraw from the waiting list. It's a very, very low rate. If someone were to be removed from a waiting list, it's more likely that they've moved out of the borough. The first question was about the prioritization.
Yeah, during the referral process, if there is certain groups, demographic groups or.
Yeah, so we will prioritise people who are currently homeless and rough sleeping. We prioritise people who are pregnant, and we prioritise people who have sort of urgent mental health concerns. So people who are perhaps inpatients, or who are very, very risky, open to crisis services to be prioritised.
Thank you.
Thank you. I'm just going to go and ask if anyone from the public has any questions.
I'd like to ask a question if I can. Two questions. One, is your diagnosis binary? Either people have the condition or not, or are there gradations? And if so, how do you cope with that? And internationally, you're sticking to the NICE recommendations, but is there work going on internationally to speed up or find different ways of doing diagnosis that are quicker that might offer another way of speeding up this process?
Oh, really good question. I think that, so I'll start with the diagnostic outcome. I think as our service, we think of people holistically and as a person. So yes, they might or might not receive the autism diagnosis, but ultimately we're trying to understand them as a person, their lived experiences, their communication profile, the information processing profile. So from the diagnostic perspective, then yes, if someone would meet the diagnostic criteria, someone wouldn't meet the diagnostic criteria, or it might be, in very rare cases, it might be an inconclusive diagnosis. We don't go with the gradation within our service. We don't follow the level 1, 2, or 3, because I think it creates a lot of confusion when people go and seek help, because someone might be level 1, but actually they have quite significant mental health or social care needs. I feel like the gradation only defines the person at the point where we see them. It doesn't necessarily capture how they might function across the lifetime. So from the diagnostic perspective alone, is either autism or not autism, but always we provide a formulation as to why they might be presenting with the needs they're presenting. The second question about, I feel like I need to look into that, whether there's work to speed up the assessment process. I think there were quite a bit of work done when it was over COVID, especially when in-person assessments were not possible. People are looking to see if this can be done online. I think just for interest, I think for us, we've learned that you can't provide an online only service, because you have to do so much behavioral observations in the room with the person. So I would say 50-50, but definitely something for us to go away and really think about. Off the top of my head, I don't have the answer.
No, because I know in the ADHD world there is a lot of work that's being done around various computerized tests that you can do that will show if you have ADHD. But as far as I know, nothing like that has come out for autism so far. But that's a really good question.
Any further questions? I was just going to ask too, in terms of from a thorough level, is there anything we could be doing in our case? I know it's not necessarily an area you would cover, but to be a more autism friendly borough.
It feels like such a lushy question.
No, I would take away and come back with.
Yeah, no, please do. And I think
No, we haven't any more money.
Thanks for the heads up.
and then I was going to say, if the committee agrees, we could make a recommendation, the ICB, that to put more investment and resources in also to meet the increasing needs. Music, it would necessarily, will never, but if we're in agreement, put that forward. Yeah. Great. Thank you so much.
Thank you.
Thank you for
Very
having
interesting
us.
discussion.
Thank you.
Moving on to agenda item 5, which is the neighbourhood services. Paper, this report sets out an update on the development of the neighbourhood health services in the borough, implementation of neighbourhood health services, and now a strategic priority of the NHS and the Department of Health and Social Care and North West London Integrated Care Facility. has been leading the development of new models for health in partnership with local governments. We've got Jeremy Gale, Rita Karia, directed by Borough Peace Partnership, Dr. Andrew Student, Medical Director at the West North West London ICB, and Anna Lally, Director of so I will be in shape for Thank you so much for coming.
So firstly, apologies from Dr. Andrew Steele. He's been unable to make it today this evening. Well, thank you, Chair, and thank you for inviting us here to present this paper. Firstly, we'd like to recognise the sort of complexity of the evolving neighbourhood health programme that's progressed over the last few years, but recognising that a lot of the concept that we are trying to implement are not new. And what we are doing, or what we've been trying to do, is to build on existing examples of really excellent collaboration that we've got kind of across the age spectrum. So if we look at children, the child health model, working with Imperial, we've now adopted as national best practice when it comes to neighbourhood health, and that links in really well with the local authorities led family health model as well. So we've got very joined up with children, and then at the other end of the age spectrum, we've got a offer called My Care My Way that's been in place for a number of years, and it involves geriatricians working with local GPs, community, voluntary sector to offer joined up care for our most frail population. So that's really what we're building on, but recognising that we've got some really new concepts as well. So things like the integrator that is mentioned in the paper, that's come out through the London Target Operating Model. That's a new way for health and care providers to work together collaboratively to respond to the asks around neighbourhood health approaches. When we're invited to attend, we had hoped we'd have further national guidance, which is imminent and has been for some time, but we're still awaiting that. That's going to set out some of the next steps and the kind of contractual expectations in the future. But yeah, happy to answer any questions of what's happening.
Thank you very much. I was going to say, I think we have seen, we've said this before, so it's just to start, it would be good to understand what you think is going to be different this time, and how it will be delivered in the kind of context of constrained resources and the wider system change. I know that's quite sort of far-reaching question, but how does it look different to someone who is using the service?
Yeah, so I guess this item doesn't link into the next one around the kind of changes to ICBs and the kind of health and care system. But I think what we would look to do, so I think initially when we started out the quiz question was how can you deliver this within the same budgets? It's definitely moved along. How can you deliver this with ever diminishing budgets as kind of all the providers come with less to the table? But that's why what we need to do is to deliver more joined up, more effective care for the people who most need it, because that will get us kind of the most improved outcomes. I think what we're trying to be much smarter about is the kind of population health management approach, and drilling down into the data to identify very specific cohorts of people that we can have the maximum impact for, and then using that to kind of test and develop slightly different ways of delivering care, so that we can make improvements for them and then rapidly sort of do test and learn and impact then on other parts of the population through what we learn through that. And so the National Neighbourhood Health Implementation Programme is something that we're a part of across the Borough with Westminster, and that's very much built on at a national level for these 43 Wave 1 sites.
If I just add to that as well. So the London Target Operating Model identified, talking to residents, are we there yet in terms of are they feeling that their health and care is coordinated? Are they feeling like they're falling through the nets? Is there still fragmentation? And clearly there are models where we are getting it right, and we certainly have with our child hubs, family hubs, and a number of other models. However, day to day, residents are still falling through the net, and it's just far too complicated across our health and care system. So the target operating model identified that actually there are key enablers that would support teams working better together across health and care. So it doesn't matter which organisation you're part of, whether you're a health professional, from social care, and most importantly, are we including communities, both in terms of their voices, but actually what are the community assets out there that we should be working with first and promoting. So they've identified a number of enabling functions, and they're called the integrated functions. And so it might be that actually if we had more opportunities like we have with the Child Hubs, where we can bring communities together with different professionals across health and care, would that enable us to provide a more joined up approach to our communities? In terms of digital, it's always a challenge. It feels like it should be the simplest thing, but actually is there information governance sort of barriers that stops professionals working together with the community as well, and with residents? The same with digital. So actually electronic files can each partner see each other's records when it comes to a resident, so they've got a full picture of what's going on for that resident, so the resident doesn't have to keep asking the same questions. So they're some of the enablers, plus that cultural change that we're trying to really build on. And the idea is that through the target operating model, the NHS 10-year plan, and everything else that Joe's spoken about, is to accelerate that. And that's why the integrated function was brought about.
And can I just add to that, in terms of this new model, how, because we have a very unique sort of sections of need in this borough, is it tailored to, for example, North Kensington and sections of the south of the borough as well, where there are deepest areas of inequality? Is it? I just don't want to see it as a sort of uniform approach in how we're looking at in context.
Yeah, and that's definitely what the kind of population health approach allows us to do, is to really look at the data and look at where the need is, and to kind of target resources for that need. And that the kind of core 20 approach is very much looking at those communities that are in the kind of 20% most deprived, and really looking to focus and target on those.
And so that's again, it's about how do resident access services. So it might be that everybody requires a certain type of service, but the actual approach, and again, we've got some really good models that we're trying to build on, and working with our community champions and others that also have that intelligence in terms of understanding for our community.
Yes, and I think within that question comes the protection of particularly the Grenfell survivors in that community, which is
resident voice, and actually that need to so that acknowledge the difference in approach.
Thank you for this paper. I guess we followed up questions that we're doing on the autism in measurement, and there's a lot of good stuff in here, but there's a lot of vagueness in here, if you don't mind me saying that. So paragraph 2.2, beautiful sentence. The overarching vision is to create a fairer, healthier RBKC by 2029. Of course, who wouldn't? But how are we going to measure that? How are we going to know when you've achieved that? By personal life expectancy gap. Okay, what is that going to be? How do we lovely stuff? But how do we know? We've seen lots of, over the last 10 years, lots of initiatives around this sort of stuff, and they come and they go, and they come and they go, but we never seem to finish it, or we never seem to achieve what we're setting out to achieve. That's one question. Then there is a plea, just a very simple plea. 2.13, you mentioned there about shared estates, you mentioned faith halls, and I just ask you to extend that in you, not just using the halls, but using faith groups as a way of getting to communities, because they are often very connected to their communities, and they're conduit for actually getting into communities. For those people also who are not necessarily already connected with health services in any other way. So a question and a plea.
So we take the second one. So I guess the timing of when we started beginning this has really followed after COVID. And during COVID, we learned some really valuable lessons about the value of faith groups and the value of those influential people in the communities to get some of those messages out. So that's definitely something we've recognised and something that we want to build on through this work. So yeah, it's not just using spaces. And that's the when we, when we complete this, we'll never complete it because it will always evolve. But that it's the neighbourhoods really embedding in the communities, and people understanding that kind of breadth of the community assets is their local post office, is their local faith group, and everything combined is all part of that neighbourhood. And how do we enable that? How do we bring some services into the community in places where people are most comfortable, because that's where they're gathering anyway. There's lots of different ways that we can do this to get it right, and for people to kind of feel a sense of ownership about it. In terms of the Bearer RBKC, that's the sort of council ambitions around that. I guess it's similar to the kind of 2035 in Westminster ambitions, and I think they've been more specific in terms of their level of ambition about how much they want to close the life expectancy gap by when. I haven't necessarily seen that, but maybe have that to hand. But I think it's a fair challenge that we need to be, and we work in a landscape where, as you're about to hear from Simon, we are constantly changing in terms of the systems that we're trying to deliver this within. That makes it quite difficult. And this is top-down policy that we are trying to deliver in a bottom-up way, in terms of trying to get it right for the people of RBKC in Westminster, in terms of recognising what our local assets and resources are and trying to shape and respond neighbourhood health to that. But yeah, I think it's a fair challenge to try and pin down what are our expectations by when, so that we can monitor against that.
I can touch very briefly, and Simon may say a little bit more when he joins us to talk about the ICB. The overall ICB will be responsible for setting the strategy and the strategic vision, and the early versions of that document very much set out a vision that includes understanding life expectancy and healthy life expectancy, and has some emerging aspirations in terms of reducing the life expectancy gap across the areas within the 11 boroughs that we're looking at. So that's something that we would greatly welcome from a public health perspective, because as you know, that is basically the core aim of much of our public health work, is to reduce that gap in life expectancy, to extend the period that people are living in good health, so people living in better health for longer. And much of the work we do at Public Health in the primary prevention space with our GP colleagues, with our community trusts, and the types of services we as a council commission are very much the evidence-based interventions that contribute towards life expectancy. So in terms of Best Start in Life, the reasons why we do things like health visiting and school nursing, because they're very much about ensuring every child has the best start in life. We maximise on the 1001 days, and we know that work there contributes to life expectancy. And likewise, some of the other interventions we have around cardiovascular disease, such as NHS health checks, some of the stop smoking work, the obesity work, really contributes to narrowing that gap in life expectancy. There is gold standard evidence bases from NICE behind those interventions. So if we look at what causes the gap, what contributes to the gap in life expectancy in our patch, it is heart disease, it is lung disease, and it is basically head, in terms of dementia and aspects like that moving forwards. So what we've tried to do very much with our voluntary and community sector is to sort of raise awareness of this. And we spoke to you previously, committee, about our Healthy Communities Fund initiative, which very much builds on the neighbourhood work. It's the work we're doing with the local voluntary sector to build the capacity and capability of the voluntary sector to engage in public health initiatives such as delivering health checks, such as delivering advice on stop smoking, and to reach some of the communities that perhaps we can't reach through our more traditional services, but are in contact with some of the grassroots voluntary sector organisations. So we're working our way through the evaluation of that at the moment, and it's something our NHS colleagues are very interested in and very keen to know more about and to understand better. But the important elements for us moving forward with the neighbourhood model will be how public health plays into the neighbourhood model, how social care plays into that neighbourhood model, and the wider council community services. And our role as curation of place, because if our environments are healthy, if we've got green spaces, if we've got good air quality, all of those aspects contribute towards not just quality of life, but extending life expectancy.
And life expectancy, like, over the last 10 years, within the Borough, what's the direction of?
So we have had some improvements in life expectancy.
So what is it? What was it 10 years ago, and what is it now?
So up until recently, we were working with an 18-year life expectancy gap. Some work has been done recently to recalibrate how we measure life expectancy, and it's also changed the units of geography within which we measure life expectancy. That is only recently released. So we're looking at 10 and 11-year gaps in life expectancy at the moment in our patch. I will say part of the reason for that is we have had the COVID deaths moving through the 3-year rolling averages, and we've also had the Grenfell deaths, which have moved through that life expectancy gap. So part of the reason for the contribution to that reduction will be changes to how it's measured. It's changes within our population as a result of the issues I've just referred to, and it will in part be due to reductions in smoking, which are quite significant.
And do we know the relative figures on that? Because what I was really interested in is these initiatives. Obviously, you mentioned the COVID and you mentioned the Grenfell are like separate issues in a way, where these initiatives haven't necessarily contributed to those figures changing. Have we any data of where all the initiatives over the last 10 years has made a difference on life expectancy?
So one of the areas I would refer to that we're very proud of locally is childhood obesity. So some of you will remember Goldborn, something that we invested in kind of nearly 10 years ago now. The learning from Go Goldborn morphed into the Change for Life programme, and it morphed into the learning for our healthy lifestyle work. We're one of the very few boroughs in London, indeed the country, who now track the trend in childhood obesity in terms of our year 6 children. So that's something we're very proud of, that we're actually not seeing an increase, we're actually starting to see a decrease.
Because that won't affect the life expectancy for another 50 years or whatever, in terms of how we measure it.
So yes, but it will roll through in due course. I mean, one of the big challenges that we do have at the moment is obesity, not just within children and adults, and our obesity approach is very much that whole family approach. So we work with the parents, the adults, along with the children. We're able to measure it a little bit more in real time with the childhood obesity rates, because we collect that data every year by our school nurse.
Thank you. Thank you.
Yeah, I have a question touching on the beginning of your question, Gerard, about what does success look like? And in very simple terms, could you give me examples of what this new creation, this new ICB will allow you to do that you could not do before? Like a very concrete example.
So one of the ambitions set out within the 10-year plan is around developing neighbourhood health centres. And so that is to put a number of services under one roof. That means that the staff are located and that patients are able to reduce the number of visits that they have to hospital. So at the moment, you may have a patient that is diabetic but also has a respiratory condition. They get invited to the hospital to manage their diabetes, then they go back to the hospital separately to manage their respiratory. Under this kind of model, what we would expect is them to be able to A, do that close to home within one of these neighbourhood health centres, but B, have that person, that whole of that person be looked at and that whole of that person supported in as joined up way as possible by having kind of the resources on tap in order to do that. So that was like real improvements to that kind of patient experience and their experience of care.
And do we know that these will, I mean, obviously from a customer point of view, it is simpler and it's better. Do we know that it has an impact on diagnostic and treatment? Or is it simply more comfortable?
So I think there's an expectation that there will be a bit of both, and that it'd be improving things for the patient, but also, if they're getting treated quicker, that's going to reduce. It's going to save time in terms of them not sitting on two waiting lists at the same time. So like the administration.
Okay, so the waiting list could be merged.
Yes.
That's what you're saying.
So I guess it's finding new ways to approach that challenge of managing waiting lists. So you would hope to bring them down through managing that way, because they won't be waiting twice.
Okay. Thank you.
Thank you, Chair. Thank you for this report. To say the truth, I'm lost. Things are changing so fast within the ICB that I don't even know what question to ask you, but there's something that I really want you to promise me. What specific measures, improvements should this committee expect to see in the next 6 to 12 months? And what data would you bring along to demonstrate this?
So some of the work, so I guess some of the work that we can commit to doing over the next 6 to 12 months probably relates to that National Neighbourhood Health Implementation Programme I mentioned earlier. So we are doing some targeted work in the North Kensington and Chelsea around patients with diabetes or hypertension. And this is looking at people with one or more long-term conditions that are kind of identified as rising risk. And so we are baselining those residents sort of as we speak. And we'll be working with those local integrated neighbourhood teams to develop improved pathways for those patients that we would hope to see improvements for. So we'll be happy to kind of share some of kind of the ambitions around those outcomes with the committee, and then we can bring it back once we've done the work in 6 to 12 months' time.
So what data will you bring back?
So we will have outcomes on their levels of attendance at hospitals, so things like non-left admissions. We will have data around things like outpatient attendances, but we'll also be trying to collect some things around patient experience and potentially staff experience. So kind of a range of measures in terms of both inputs or outputs, but also trying to look at some outcomes as well.
So that will be presented in 6 to 12 months. Anything else that's possible?
So I guess we can bring some updates around some of the estates work that we've got. So we've got the makings of a neighbourhood health centre at Violet Melchett, where we'd be very happy to invite members of the committee to come and see some of this work in action that might bring it to life a bit in terms of how teams are starting to work up in a joined up way, how we're offering more relational care to residents through things like neighbourhood navigators. That's a new offer for them. But what we are hoping to do is to get access. So we're in half the building at the moment, and we're hoping to get access to the other half of the building that will allow kind of new opportunities in terms of services and putting more things under that roof. So we hope to be able to kind of bring to the committee details of that. Also, we are expecting within the coming months a new smaller site to be opened in Goulburn. So moving one of the GP out. There's 2 practices in the same building at the moment, opposite Drake Tower. One of those practices is moving around the corner to a new dedicated space. But it's got expanded space to do lots of work with the community as well. And they're really keen to kind of bring the community into that site to develop the office, so we can bring some of that information as well.
Is there any possible work happening in Notting Dale for Porter Health Outcomes?
So we will be so I guess the work we're doing around the ENIT programme is around across the whole of the North, Kensington and Chelsea. So we can bring some of that information as well.
And bearing in mind, I live in Notting Dale. This is why.
Yeah.
Yeah.
One of you.
You go first.
Just a supplementary to that. Those are all great measures, but they're all, if you like, they're all place-based measures. And when we start to see that X% their blood pressure is reduced, X% their diabetes who were type 2 are now no longer, when we're going to see the health outcomes rather than the the building outcomes. Does that make sense?
Yeah, that does. And it's difficult to say how long that impact will take to demonstrate, because we can make changes now, and some of these things, through some of this work, we may case find, and we may case find and identify people.
Yeah.
And
It would be nice to
communities
see
that work
some
with each
health
other.
outcomes as well as property outcomes.
Yeah,
That's not too seen.
yeah, no, that's a fair challenge. And I guess so. We've got there is a North West London dashboard at the moment that's reporting on a number of health outcomes, from uptake of IAPT, obesity rates, smoking rates, non-lecture admissions. There's a whole range of outcomes on that dashboard. The changes that Simon's going to talk about shortly means that kind of everything's getting reviewed. So what we've been doing in North West London is getting compared with what they've done in North Central London to kind of bring them together. So there will be a set of outcomes. I just can't guarantee that they'll be the same ones that we're monitoring at the moment in North West London, because there might be a combination of those. Because what we've done, so I think what we've done at the moment is without any contracts and without any direction other than that we've kind of self-generated within the place-based partnership. However, what we are expecting to come down the line, both nationally and from West and North London, is some more specific direction and some contractual expectations when it comes in terms of neighbourhood health. We don't have the details of that yet because it's not firmed up, but that may kind of set some expectations that then means that we need to adapt some of what we're doing to kind of meet what's being contracted or expected.
Thank you. Sorry, Mark.
Thank you.
Thank you. Oh, no, go ahead. The question I had was just, I guess one would hope that with things becoming more cohesive and integrated, that there'll be cost efficiencies as well. And I was wondering where that money will then be reinvested, and if there's anything you can commit to now in terms of, I don't know, preventative measures or initiatives that you've got in mind. Sorry. And then the other question was just, I didn't understand the challenges paragraph at the bottom of page 51. Which was just speak to that a little bit more. I didn't know what you meant by cultural resistance, and also what was meant by workforce capacity limits. What are you able to kind of just flesh that out a little bit for us to understand?
Yeah. So in terms of cost savings, there is, the ambition is that a lot of what's being delivered will deliver cost savings. There are proposals going through West and North London around the future of neighbourhood health at the moment that haven't been signed off yet, but the plan is for a 1% investment in neighbourhood health for each of the next 5 years, so moving up to 5%, to support the kind of left shift of activity, so moving activity out from hospitals into the community and releasing savings because it's cheap to deliver it out to the hospitals. That comes with some rather ambitious targets in terms of the number of non-lecture admissions that will be reduced as a result of this investment, as well as the number of kind of outpatient attendances will be reduced. But the intention is to reinvest that money. I think
It's quantified.
so there's I can't myself now, but there are some and when once these things are finalised, they'll probably be more shareable than they are at the moment, because they're very much work in progress at the moment and working assumptions at that West and North London level. But yeah, the intention is that money would get reinvested in delivery, and so you take money out. People are talking about the left shift and this kind of acute within the 10-year plan. They talk about moving from acute to community, and so by moving the activity, the money needs to move as well, so that you're investing more in the community and then investing more in prevention going forwards, in terms of scaling up what's that. Lots of the work that we do at the moment is strengthened by investment in the voluntary community sector and the activities that we have available for them. Ultimately, if that left shift happens, you're kind of being able to kind of
bulk up that offer within the community.
And how confident are you that those savings will be?
I haven't made the assumptions, but I would be.
I mean, it's just there's a paragraph in here that talks about reinvesting in. So
I think it will be possible to have a level of reinvestment. Some of the figures that I've seen bouncing around the system are somewhat heroic, and I wouldn't put my name to those. But I think there will be a level of cost savings that we will be able to kind of reinvest. But the scale and the level of ambition being put upon neighbourhoods is absolutely massive. There was a second question around the challenges. So when we're asking people to work in new ways, we're not able to kind of take away people's day jobs. There's an element of needing to ask people to kind of do something slightly differently while they're still needing to deliver things in the way they have been historically. And so there's with a lot of this transformation work there, with necessity, an element of kind of double running before you kind of can prove a concept and fully adapt. And I guess that's where some of the kind of workforce capacity challenges are, that we're trying to get. I think we're succeeding at getting the buy-in of people because people are really keen. People know that the way that care is offered at the moment isn't as well as it could be, and so there's a lot of appetite and engagement in what it is we're trying to do. But that doesn't take away that everybody within the system is hugely under pressure at every single point in the system, and so it's very difficult to get people to be able to try some of the things that we're looking to do.
Thank you. So it's sort of, sorry, just to clarify, so it's kind of depending on the willingness of people to work in this very new way.
Yeah, so I think it's led by organisations, isn't it? It needs, and within our Borough Place-Based Partnership, we have got the commitment and buy-in of all of the organisations, and whether that's our giant acute trusts that we've got in the north of here, in the south of Penchell West, because we're doing things over by the borough, we've got the power of 2 local authorities and joint public health offer, GPs, community trusts, mental health trusts, everyone is bought into this. There is something about how do we translate that enthusiasm from the people that we're having our conversations with, to make sure it infiltrates to absolutely everybody on the ground, which is a real organisational development challenge within each of our individual organisations that we kind of need to address jointly, which again is a hugely challenging thing to do if it's everyone within the community, from the communities team to the housing team to the social care team just within the local authority, and then that's kind of repeated across every organisation. It's not easy, it's complex, but we have the right buy-in from the partners, and now we just need to kind of maintain that momentum.
Can I just come in on that? I think there's something about the frontline teams across health and care, certainly because they're building relationships with communities as well. They know that there's a better way of doing this. And traditional models of care that we've developed over time has meant that actually, even if many of our professionals wanted to do what they believe is right from a holistic perspective, there are still a number of competing demands, a number of forms that they have to fill in, etc. So they want to do this, and the frontline teams are actually saying this is the right thing to do, but we will have to work with them to actually identify what do we enable them to stop doing so that they get to do this collective approach where every contact counts, where they're actually able to go into a family's home, a community's home, and observe what's going on for them, ask the questions, spend more time with those families, they build the relationships, and actually therefore there's less people involved overall. They've got a trusting relationship with the professional that's seeing them, but actually to do that we need to work with our frontline teams, and actually there will be resistance because at the moment they've still got their pile of paperwork to do and a list of patients to go out and see. So that's why Joe's talking about actually there needs to be an opportunity to perhaps double run or test and learn, work with the frontline team to say, actually, if you did this collectively as a group of individuals with your resident, what would you stop doing? What would we do differently? What could be enabled through digital or a different way of working? Mm-hmm. Also, there's lots of referrals bouncing around the system. So people refer people on to someone else. And, you know, you could be referred 3 or 4 times about one issue and work through a number of different professionals. This is an opportunity to reduce that and actually go more towards introductions and actually saying, I've just gone to see a family, these are some of their challenges. Now, if you're working in a neighbourhood way, you've got the relationships both with the residents, but also with each other. So you actually have less opportunity, less need to send an email, to make a phone call. It's actually working closely with individuals that also know that family. So there's a big shift in how we're working.
So I would say it's kind of a mindset approach. Making prevention everyone's business is very much about a shift in mindset. So I think we've got some really rich examples where some of this is starting to emerge locally now, some of which are referenced in the paper. So when I think warm and well, we have a nurse from the GP Federation who, alongside a housing officer, a housing repair man, visits people in the community who GPs have identified of having concerns around respiratory related to mold and damp, etc. We piloted that initially in Goulburn, but now it's being expanded across borough. And when you see the community nurse presents with the housing officer and their stories and how it's changed their practice and how it's changed the conversations they're having with people, I think it's really, really interesting. Not dissimilar in some of the work we're doing at the council with embedded mental health social workers within the housing team and housing officers. And again, it just changes people's mindsets. So some of this will happen gradually over time, but I think some of it is quite exciting. And there is something around winning the hearts and minds of the workforce that this is an opportunity as well as a threat and as well as something that's driven by cost savings and, you know, night passion.
I think a lot of people want to work this way. It's just about whether there's the kind of motivation to kind of free people up and give them what they need to be able to.
Yeah, very efficiency. I mean, that's an interesting point about giving people what they need to do what you're asking of them. And I guess what I'm sort of reading here about the integrated team, and obviously it sounds like a good way of working. You talk about the voluntary sector partners, so I guess I'm kind of surprised that some of them aren't here to talk about this approach, and I think when we do this again, I'm sure we will, I think it'll be great to have them, and I think we really do need to hear from them and see whether our voluntary sector partners are as on board, or do they have concerns, do they have what they need. I noticed the fact that there's no financial implications to this paper. So I guess, are we asking them to do more, or how are we going to compensate them for that? I think a lot of them are already under quite a lot of pressure as it is, and probably going to be more under pressure. And kind of added to that, you know, you talk about the co-produce with residents, communities and staff. We love co-production, I think it's a good thing. But I think it'll be really great to see a list of, you know, those organisations who were involved in that co-production. Yeah, I mean, I'm interested in their feedback and what they think some of the challenges will be, and I'm guessing a lot of them will be around resources, and they seem like a key part of making this work. So how are we going to hear their voice and hear what they've got to say about the movement?
Yeah, so I guess we can commit to making sure they are part of the panel presenting in 6 to 12 months' time. In terms of, so we've mentioned the kind of joint integrator approach that we've developed across the borough, and within that, the voluntary community sector are taking on the role of participation and taking a lead role in terms of participation, in terms of those enabling functions. And so that is participation of our residents and how we involve our residents, as well as thinking about staff. And so in taking that active role, they're very much central to delivery, and they're also there to hold us to account, so that they are part of our conversations in terms of when we're developing this, to make sure they're bringing the voice of the residents in if we're not, and to think about how do we land some of this messaging. So one thing we've been talking about is, we've already mentioned the complexity of this, and how do we explain this in the simplest language as possible for our residents, so that they and how much they need to know and when. Is it the point that services are changed and they're very different and they get a very different experience, or do they need to know, we're going on a journey and we're doing this work behind the scenes to make sure that all the health and care partners are aligned? Because if you speak to a lot of residents, they kind of think, well, we're not like that already. So you kind of sort of shine a light on how not joined up things are, rather than get the message across of where we're trying to get to. In terms of so there's no money, we're not asking for money today. There's obviously investment across all of what we do. Within the My Care My Way model, there is investment in the voluntary sector, and there are some self-care contracts that the ICP continues to fund that are a really key part of that My Care My Way model. We have I think we're in the second year of something called Health Inequalities Transformation money, and the majority of that money was given to the kind of neighbourhood leadership teams to make calls about how it's used, and that's been a lot of that's gone into funds something called Vibrant Healthy Communities, which is a voluntary sector led programme. It's really about bringing together our voluntary sector partners. They've done work in the first year around something called Screen Detect Protect, that was really about increasing screening rates, and then this year they've been really focusing on mental health, and particularly within some of our more vulnerable groups, and so we do try to fund the voluntary sector where we can, but recognising, like I said, it's a limited pot of money, and that will get more challenging. One thing that the place-based partnership, I think, has a role in doing is to kind of continue to make that case to Western North London and other funders that investing in the voluntary community sector is investing in prevention, and if we really want the left shift to happen, we need to have a vibrant voluntary community sector, and if we have organisations falling over, we won't be able to offer the services in the community that take up so much pressure off the system. And I was out in Shepherd's Bush, just across the border last week, and they were talking about how they'd stopped investing in community champions, and the kind of impact that had to those local communities. And thankfully, it continues to be really well supported within RBKC and Westminster, and we really see the value in that, because you're not just investing in the community champions, you're investing in the army of volunteers that go alongside those community champions and do so much work that takes the pressure off the system, and that really is the neighbourhood working. And so we've been having I think up to 7 of these neighbourhood navigation events that is really about bringing together all of the roles across the system. And there's a huge number of voluntary sector roles within that. So we've got people from Age UK run the Men's Shed. We've got all of the health and social prescribing coordinators that are part of My Care My Way, and we run what we call neighbourhood market stalls. And the most recent one, I think we have 25 different stalls, some of them services, some of them local voluntary sector organisations. And this is all about understanding what is out there and creating that kind of culture of connection and sharing, and trying to kind of develop a community of practice across them. And so that's helping the voluntary sector understand what's out there and helping some of the kind of health roles be connected into the voluntary sector. So it's really about building that strength and togetherness. So there's definitely a lot that we're doing to try and foster and develop the voluntary sector as much as we can.
I mean, I guess the only thing to add to that is this seems to be a pretty important part of your integrated model. And yeah, I mean, they need to have the resources that they need to deliver whatever it is that you want from them. So I think we need to involve them if we're going to put this responsibility.
And just adding on to that, I guess one of the questions I had to kind of maybe round up our questions was just surely a lot of the funds that you need to put into these services are tied up in hospitals at the moment. How do you move that away when the demand is not going to go from that? So I mean, what's the kind of ambitious plan of trying to find the funding that you need to make this all happen?
Yeah, well, so this kind of reference to earlier in terms of this left shift money identified by West and North London. So identifying 1% of the acute budgets in the first year, up to 5% in year 5, that it begins to start to take that money out to deliver care in the community and shift the activity. So that's what's intended to happen with that.
Health Watch, do you have anything Mary?
Yeah, I suppose mine was really an observation that this seemed an incredibly process-oriented paper. And I mean, I thought paragraph 216 was the purest example of NHS speak I'd ever heard or ever read. And in terms of communicating with the public, that's what your aims and aspirations are. That's sort of a masterclass in how not to do it. And I suppose I was disappointed, and I think that's echoed throughout the committee, that the lack of emphasis. There is mention of productivity in 213, but productivity and outcomes and measuring what we're doing. Because if I was just, I've been to lots of adult social care and health committees over the years, so I sort of understand what's going on in here. But where I'm a member of the public, I'd see absolutely no benefit in this to me at all. It's just not grounded in reality, and that may have been an interpretation of what was asked for in this paper. But I just think in future people really need to know, So the last paper, for example, had some patient stories in it, and I think that's quite a powerful way of talking about what difference is it going to. Is it going to mean I'm going to see my GP quicker? Is it going to mean that I'm going to get referred to the hospital quicker, or not need to go to hospital because you're going to do it there? All of those things are really important to the people who use this service, and I kind of just didn't get a flavour. And I don't mean to be unduly negative. It would just be nice to have an aspiration for next time, perhaps when this committee talks about it, that we'll sort of see more of that. And less in paragraph 216.
Any further questions?
Yeah, I'm just thinking about data protection and privacy and training for health whoever it is, the volunteers or whatever, who's going to be having sort of indiscriminate access to this sort of sensitive information. I think is there going to be some sort of training these people, or how are you going to go about that sort of thing? Do you know what I mean? Because it's not a system integration. You see what I mean?
Speak up.
Yeah. So information governance is really critical, and I guess it's understanding what's people like. We're not going to just open up people's records to anybody who's volunteering in any kind of way. It's governed by so we have kind of roles-based approach to accessing records. So depending on what your role is depends on what records you can access, and you need to be able to demonstrate what that need is. So if we're trying to change systems and expand things for additional people to have access to records, you need to kind of explain why it is and what they're going to be doing with it. So you have to have a really clear purpose to kind of expand data sharing beyond direct patient need.
So there's a sort of training for that, these people that are going to be accessing that information.
So anybody accessing patient data, which is fully trained and have to go through kind of mandatory training around information governance, data protection, and all of those confidentiality and things like that.
And also, most importantly, if you're accessing a person's data, you're supposed to be able to be their caregiver instead of just snooping on their record.
Exactly.
That will be logged. So if someone asks for FOI, it will be flagged up. And will there be any punishment in regards to that? So, for example, if I'm going to look at someone's record when I'm not in care of that person, what penalty would that person receive?
There are HR policies.
There are.
Absolutely.
Okay.
Every organisation will have them.
Yeah, but do they get carried out?
They do.
Okay.
And And I wondered whether it would actually, Joe mentioned earlier on, I think it would be helpful if committee were willing to come along and see some of this work, so that it brings the stories
I think that would be very
alive, so that, because it's quite abstract, it's also, we're living in a lot of ambiguity. So I saw a lot of nods about, yes, it's the right thing to do, but actually what are the outcomes? How can, are we actually going to be working with local communities? The voice of voluntary sector, the voluntary sector are actually on our board. They feed all the way through. They are developing community metrics, which is led by communities about what would be different. But we are at the beginning of this journey. I know you've seen several versions of this journey, but I think it would be helpful if you came to see
I was
some of the
telling
current models.
the recommendation that firstly, I think realistically maybe 12 months is a good time for you to come back. So we have
6 to
some
12
more-
months.
I mean, we're probably gonna have to. I mean, we won't necessarily be committee, and when the next comes back in 6 months, we won't be. So we won't have another meeting. But if we find the right amount of time for it to come back to committee with some much more kind of. Firstly, I think before that meeting, it would be good for the committee to go on visits to understand how the services working, and also so that we have much more evidence-based data, or from the works that you're talking about with your pilots in North Kent and Chelsea, so we can see, I think as Gerard said, the real improvements that are happening in terms of
in health measurement. I think Gerard, your comment was about health health criteria. And I think that's very important. I mean, I rally with Mona's point about the financial gain, but I think, and that's what I was saying earlier, the comfort of the customer is very important. There's no doubt that it has a positive effect. But what we want to see is health improvement.
And the only other thing to add, so I mentioned the national guidance that we're expecting. We're expecting that to set out a very clear role for the Health and Wellbeing Board in terms of the responsibility for oversight of neighbourhood development going forwards. So that will hopefully give a better opportunity, another opportunity to kind of have oversight.
And I think also taking from Anne's point that next time you come back to have some knowledge. But thank you very much.
Good, thank you.
Thank you. And moving on to the final paper, which is the integrated prepared for water new model and merger. This report sets out an update on the development of the new model integrated prepared board following the decision to merge the North West London ICB and the North Central London ICB into a single organisation. We have Simon Hope, the Borough Director of West London North NHS, North West London ICB, and Anna Riley. And Martin and I will lead you to the report.
Okay, well, I'm going to take it as read and really look for questions from the people. Some of it will have been covered already in the previous item when you have already touched on some of the changes that are afoot in the NHS. At a very high level, the ICBs in North Central London and North West London are merging and will formally form a single ICB from April 2026. That's part of that is going to mean a 50% reduction in staff in the new organisation. One of the consequences of that will be that there will no longer be a local borough-based ICB team in the way that we're used to. So for those of you who've been around long enough, you might remember. Do you remember CCGs probably? Yeah. Maybe even PCTs? Yeah. Okay, I'm not as old as I thought, or you all are as well. And you'll therefore be used to having a statutory borough-based NHS organisation that you interface closely with, and that is the local commissioner and sets strategy, decides where money goes and all the rest of it. That's not going to be the case any longer. We will have a strategic ICB across 13 boroughs. That's the North Central and North West as we are at the moment. That's 12 places because we work as a 5-borough here. And there will be a very small team at that strategic level that will develop strategy for implementation across the 12 different places. And at the place level, there will be something, we tell you stuff you already know, we're called a place-based partnership. And that will consist of local providers, NHS providers, so mental health trust, community trust, very good to see them here before, because that's the face of things to come. A few trusts, obviously, primary care, and the local authority is a key partner, and the voluntary sector. So, you know, the ICB is getting out of the way here. There's not going to be this statutory organisation at the borough level that called the ICB, that is a part of these conversations. That is very often the convener of work streams and is project planning, programme managing, coming to you with lots of data that you'd have asked for around vaccines or, you know, screening rates, whatever it is. I've been here enough times doing those and know the kind of things this committee understandably interested in. Those sorts of things will in future be the responsibility of the place-based partnership. So that's the coming together of local partners. The face of place is the thing that was sticking in my mind as I was going through the slides again here that the ICB's produced. The face of place is going to be the local providers. So that's why I was very appropriate having CRCH here before. And when you want to talk about things going forward at a local level, and it's often been the case in the past anyway, I think, but it will be the providers that will be the people coming along to speak to you rather than somebody from the ICB such as myself. So, you know, the kind of stereotypical grey suits are being shoved out of the way, and the providers are stepping in, along with the local authority, obviously, and the voluntary sector. And, you know, when you say come back in 12 months' time, it won't be the ICB doing that. That will be the place-based partnership. And Rita, obviously, is here as the managing director of the place-based partnership. There'll still be a link to the ICB of some sort, but it's still to be determined what that will look like, because they're going to be covering 13 places. Sorry, 13 boroughs, 12 places. And I don't think it's realistic, personal opinion, that they are going to be able to routinely attend scrutiny committees and get into very detailed conversations at a borough level about the minutiae of what's going on in that place. And that would be the responsibility of the place-based partnership. It's quite a big change. But in many ways, it is, you know, I think a positive thing. It's a move towards integration. We've just been hearing about how important it is to get more integrated services. And I think there's a view that the ICB's been perhaps in the way of that. The ICB's only been around a couple of years, but commissions have been in the way of that maybe. And that what we need to see happen is providers coming together, working more collaboratively, getting out of their silos, creating integrated teams, and all the benefits that would bring that have been talked about during the last item.
Thank you. I just want to begin by acknowledging that I do think it was a very complex paper that even as a committee who read through NHS papers and papers of this type a lot, it was not easy to translate necessarily into sort of practical implications. So I think that's probably fair to say around the committee would agree with that. So I was really hoping that we could go into more detail, sort of set out in plain terms what is actually going to change on the 1st of April and over the 9-month transition period, and what residents and borough partners will experience.
Sure, okay. The paper itself is produced by the ICB for all boroughs, so it's not an RBKC paper. I'm very happy to feed back what you said, but it is intended to be a paper that is consistently presented at all relevant meetings of this type. So that answers that. As far as describing what's going to happen, hopefully I just did that. I mean, the team that you are used to seeing coming here from the ICB will not be here. There will be something called a place-based partnership, which is already meeting anyway. It's been in place for a couple of years. James Benton is the chair of that, along with he chairs the board along with Bernie Flaherty, who I assume you're all familiar with. So, you know, this is something which is it's sort of been embryonic and growing and developing over the last, I guess, 18 months, and is now going to very firmly be the central entity at a place level that you will all be interfacing with. And the likes of myself won't be around anymore. There won't be an ICB team for committees such as this to link in with. There will be at a sort of north central and northwest London level up there, a very small team of people whose job it is to work with place-based partnerships But quite exactly what that will look like, how it will work, yet to be determined.
But just going back to, I mean, you were talking about a 50% cost reduction, and what I'm trying to focus on is the patient. How is their life on April 1st, for example, with the services that they might have experienced? What does that look like, and what do those changes look like?
Well, the patient, I wouldn't have thought will see any significant difference on April the 1st.
Or in the transition period, what
well, the patient won't see any difference as the sort of deck chairs are moved around in the background. You know, this is the Mr. Streeting and politicians who sit alongside him decided that the money that is currently spent on having borough level organisations such as we have at the moment is not a good use of the NHS and taxpayers' pound, and that it should go to the front line. And so, you know, ultimately, I think you could probably say that based on that argument, I'm not here to defend this, but based on that argument, that patients should benefit because it's 50% less managers, you know, sitting at their desks making spreadsheets, which, you know, is money that will be spent on the front line. So, you know, I mean, I can't really say much more than that. The hospitals will continue to see patients, as will GPs and so on and so on. But there should be a relatively small amount of money extra, which will go into the front line in some form.
And in terms of scrutiny, which I think you're saying that no ICB will ever be at scrutiny again, that's something which I think we felt at a North West London Just level, and also here is, yes, you're saying certain people will attend, but I mean, scrutiny is an important part of the strategy framework, which is in the ICB constitution, I'm pretty sure. So sometimes it doesn't really feel that reflects and comes through to our committees that are only here to essentially cooperate and work with you when we're seeing consultations and changes happen. So it just doesn't, I wouldn't say it, we've had conversations at a Just level where it doesn't necessarily always feel hugely respectful that it's dealt with in the way that it is.
Yeah, I mean, I don't think I said that nobody will be here again. I think I said that that's still to be worked through. And where big service changes that will impact significant populations are taking place, and I'm sure that there will be leads from the ICB that would be doing the rounds of scrutiny committees and having conversations, most obviously focused on those that are most affected at the moment. Brompton looking at some changes you're probably aware of, and RBKC clearly will be part of the conversation there. But it certainly won't be the case that in the way that, you know, Luke emails me at the moment and says, can you come to the scrutiny committee on such and such a day, and your team, you know, coordinate and organise for there to be presentations about A, B and C. There won't be somebody like me to receive that email and make that happen in the way that there is at the moment. I think that would be the responsibility of the place-based partnership.
Okay. Well, I think that one thing that I raised at a number of JOS meetings over the past year and a half is a kind of comms plan as to how you actually see scrutiny moving forwards and who will be attending and how it will look, because we never received that. And it's still to this day, we're very unclear as to what scrutiny looks like from the ICB and senior NHS level. So I would really press that comes forward to a North West London level, because as you say, I think it's 14 boroughs that are going to be coming under this, or 18.
13.
And it is still important. Every borough is different, and in order for each voice and each demographic to come through, there needs to be a plan as to how that's going to work.
You'll get no disagreement from me on that. You know, I would kind of say, without it being too much of a cop-out, it's above my pay grade. I mean, those conversations are happening.
I know. I mean, there's something that Rob heard a year and a half ago.
Yeah, and now we've got the chief executive appointed to the ICB. After 2 months, has actually left to get a new job, and we now have a new acting chief executive, as I'm sure you're aware.
Yeah.
So, you know, those conversations are happening at that level. But I'm afraid I would love to be able to help with that, but it's.
So just quickly on the staff reduction. So you touched on that. So there'll be staff reduction, and then earlier you said you won't see any more grey suit people. So that seems wonderful news to me. So the staff reduction, do we know if it's going to be 100% grey suit
people, or is it going to be people who actually have an impact with patients?
Well,
Can we touch on more details on the staff reduction?
the staff reductions is in the ICB, so that isn't patient-facing roles.
Okay.
There are certain functions in the ICB that consist of clinical staff, do things like continuing healthcare assessments.
Yes, exactly.
Pharmacists, they're excluded from quite a lot. They're going to be transferring out into other organisations, but they are on the ICB payroll, so there may well be certain reductions.
So those people will transfer.
They're going to transfer to local providers. I mean, again, that work's still being undertaken as to which organisations they're going to transfer to, because for certain of those functions, I think continuing healthcare as an example, it's quite difficult finding anywhere that wants them.
Okay, so that was my next question. Are there mechanisms in place to avoid basically a drainage of critical labour? So are we retaining our pharmacists? Are we retaining all those critical jobs and well-trained people from the ICB to move to the community?
I would suggest that there will definitely be people leaving who have played a valuable role. There's a big voluntary redundancy scheme that's been put in place. This is across the NHS, it's not just locally here.
Okay.
And very significant numbers of people, as the grapevine has it, have been applying for voluntary redundancy and would say it's an opportunity to do something different with their life.
And when do you feel that for this borough will have a better view on staffing effectively? We will have, because the 1st of April seems to be very, very soon. So it seems that between now and the 1st of April, we don't have much time to get a clear vision of who are going to be those staff leaving and who are going to be the staff that we're able to retain.
There's currently a staff consultation underway. It's just ended, actually, the results of which will be announced and shared with staff on the 23rd February. And the new structure at that point becomes, I don't know that it's public knowledge per se, but becomes certainly available to staff. And those posts will be filled at that point. So, in terms of comparing a before and after, I don't think there's any plan to do that and share it publicly with a committee such as this one. And in the same way as if the local authority was going through a restructure, I don't think that we would be asking for what the new structure is, what the old structure was, and who's left. But there is a new structure that has been developed, and recruitment to that will be taking place during April and May, and it will be, I think, fully staffed by about June time. And inevitably within that, with a 50% reduction, there will be people currently who, it's not frontline clinicians per se, but it's definitely people who've been involved in developing clinical models and what have you who are going. So, as was said before, I think the view is that the providers will step up here. It's challenging because providers themselves have very challenging cost improvement programs that they themselves are putting in place at the same time. If you've been reading the press about this, then it is very controversial. It wasn't in any manifesto. Nobody knew this was coming. And a year ago, suddenly it landed. And a lot of people think, you can probably, from my tone, tell what a lot of people think. Not people such as myself, but sort of health commentators with a lot of gravitas.
Okay, thank you. No further question. I'm just going to go to Monica.
Yeah, it's just a really quick one. So 50% of the workforce is being lost, and at the same time, there's going to be like a focusing away from sort of service delivery and just to commissioning. So just in practical terms, what might that look and feel like? I guess it links back to Lucy's question. What is going to be lost in terms of these sort of the services that are being delivered at the moment that the ICB is going to be relinquishing the role of providing? What are those services? The sort of clinical services that are being delivered that the ICB is going to move away from. How is that then going to be picked up?
I mean, the ICB has not delivered any clinical services. It's done things like clinical assessments for people for funding purposes, as I mentioned, continuing healthcare. But the ICB has been this sort of central organisation that has held the funding at a local, well, it's not even at a local level, in fact, it's been at a North West London level most recently, whereas the CCG prior to that was local. And it has, I guess, sort of defined at a local level what money ought to be spent on, much more than potentially would be the case going forward. Is this move towards something called strategic commissioning? So, at a strategic level across these 13 boroughs, 4.5 million people, I think it is, the ICB will set strategy. It will set some sort of, going back to the previous item, neighbourhood commissioning framework. And within that, I'm sure that it will include a number of deliverables and the sorts of metrics that you were talking about. That neighbourhoods will then be performance managed, for want of a better term, that gets people's hackles up. But, there will be some line of accountability between place and the ICB. But, as far as anything being lost, I think the argument, and I'm only going to repeat what the government's argument is here rather than my personal view on it, is that nothing will be lost, but that a lot will be gained. The money will go to the front line, that local partners will be able, by working together, to develop more integrated services through closer relationships, and that patients will benefit as a result.
Okay, so the point about strategic commissioning activities being the focus, and then the operational or delivery focused functions, those are going to be lost.
Yeah.
So what are they specifically, and whose responsibility will it be to pick up those duties?
So responsibility will be the place-based partnership. We heard before about something called the integrator, which is this coming together of local partners to develop a sort of function that will be an organisationally neutral function. I'm sorry, it's going to sound terribly, it's almost impossible to describe it without sounding very jargonistic. But partners coming together will somehow resource, let's think of it as a team of people that will sit within an organisation such as CLCH, for example, and that will work for the place on developing pathways, looking at things like vaccinations, immunisation rates, bringing together partners to develop new services, all those kinds of things, which is what the ICB has done until now.
So it's shifting to the community, essentially.
In many ways, it's saying that the things that the ICB has done is it's going to move to this local place-based partnership, and the place-based partnership will have working for it this thing called the integrator, which hopefully everyone will throw a bit of money into a pot to resource, and that team will do what the ICB team has done up until now. A bit of a problem in that there's no, at the moment, money on the table to make this happen. But the 1% that was talked about before that's coming out of hospital contracts is a potential source of funding for this. So, I think it's work in progress, let's put it that way.
Jared.
Simon, thank you. And it's just interesting, the fact that you rattled off all those initials. I mean, this is yet another one, isn't it? And one would just think, my question was, how long is this going to last before there's yet another set of initials that come to take over? So if you're sensing any degree of fatigue or whatever, it's initial fatigue and initiative fatigue. Just again, like the last session, you mentioned that the money that's going to be saved will be put into frontline. It'd be great to have some real concrete. Does that mean there's more GPs, so it'll be quicker to see a GP? Does it mean that, I don't know, what does it mean? And that this paper's great, but I don't see anything that says this is going to mean that X, when the patient goes to Chel West, I don't know, whatever. And that will be really useful for us as non-National Health Service practitioners to understand what the impact of this.
I mean, I agree, but you're never going to see that. I've nobody anywhere in the entire NHS would be able to do that. Seriously, it's not. Nobody would have calculated the money saved through a 50% cost reduction.
So we're never going to know. We're never going to know whether it's worked.
I mean, this is the NHS we're talking about. I mean, again, how do you define anyway whether something like this has worked? I think in an organisation the size of the NHS, it's completely impossible to really come up with very specific metrics as to how something like this plays out over time. This is a long-term strategy. How long-term?
Well, it won't be long term, will it? Because it'll be another set of initials in 2 years' time to take over from this set of initials that took over from the last set of initials that took over from the last set of initials.
Yeah,
Thank you, Madam Chair.
Thank you.
I mean, yeah, I don't mean to be too flippant. I think there were a number of questions asked, which are detailed in the covering paper. I think the papers here do answer. I appreciate their complexity, and I'm sorry about that, but it isn't really our role as a local team to develop a local paper. We were specifically told this is the paper that you take out to partners. So I don't even have any discretion about that. Because everybody was, the idea is that everybody receives the same message, albeit in a very complicated form. And I think the answers are in there, and hopefully I've covered some of them. But the honest truth is there are no easy answers to any of this. This is a change that, as I was just saying, came out of the blue. And I think a lot of, if you go and speak to the boss of the King's Fund or the Nuffield Trust or whoever it might be, then they would probably find it quite hard to explain and justify what these changes are all about.
If they found it hard, we find it hard to understand it.
Yeah. So I can fully empathise and sympathise with you sitting there thinking, what the hell's this paper about and what's he talking about? But I have no other way of communicating to you.
Do you want to? I've got a couple of questions. If anyone has questions. Taking it back to a sort of more serious on figure 5, could you talk us through and confirm what was sit where after, I don't know if you're going to answer this, after transition, particularly in reference to safeguarding? It's on page 79. So what we're talking about, especially in terms of safeguarding, but how this was, where everything will sit where in terms of this figure.
Where this box review for transfer.
Yeah.
The purple box in the page.
So if you just concentrate on safeguarding.
Safeguarding, I think, is still, in the conversations, as it were, in terms of it not having yet, as far as I'm aware, certainly, been found a permanent home. So if it doesn't have that by the 1st of April, it will stay within the ICB until a permanent home has been identified. And there are a number of functions that sort of fit that description, where conversations amongst partners are still underway as to where ultimately that function will sit. Okay,
so it's not going to be a case of that's reassuring here, at least.
Yeah, and that's the statutory. There are certain statutory functions that absolutely have to sit within statutory organisations. And as you can say, it says review for transfer. So transfer over time. And it talks about the Health and Care Act of 2022 allowing for this.
Okay. And then in terms of just cuts and pushing of payments potentially to local authorities or frontline partners, given the cost reduction, how are you reassuring to us that ICB savings will not result in additional sort of underfunded pressures for councils and frontline partners?
I don't think that this exercise, because it is purely a reduction of staff, it might result in more pressure on local authority staff who are working within the local system, I guess, because, if I think at the moment of myself and my team, we meet regularly with council officers and we, share thoughts with, the likes of Anna. We discuss things, we share information that we may have, and it may be that there's more onus on partners at a local level to do more in the absence of having a local ICB team. I think that's definitely possible. As far as funding for services, then that's very difficult to say. If we take something like the BCF, obviously there's a lot of money invested there that does fund, that flows into the council to fund services. And that's been under review for quite a long time and will continue, I'm sure, to change over time. I guess that the risk, we talked about this a lot, the risk for a borough like RBKC is that it is perceived, and if you use certain metrics, it is demonstrably better off in terms of health outcomes than other boroughs that are going to be within this much bigger ICB. So if the bigger, the new ICB takes a view that it's going to start moving money around and targeting more deprived areas, that's a risk for a borough like this. Now, I know that Anna would say that actually our health outcomes overall, they mask areas of deprivation that have got very significant problems in that we've talked about here. So, but they're definitely a risk for a borough like RBKC, where if you compare RBKC's overall outcomes with other boroughs across the other 12 boroughs, then it would fare quite well. So by moving to a bigger footprint, I guess it does create a risk that over time money might flow out of RBKC to other boroughs that might be perceived to be at least in greater need.
And then just one last question, and I don't know I appreciate the fact that I think your previous CEO left in 2 months, and now you have a 9-month interim CEO. But I wouldn't say it gives me a huge amount of faith when someone's going through a transition period that they're in for a interim phase, because you want to kind of take it. So is there a plan for? I'm sure there is a plan for a permanent CEO, but if you were to find someone now, it just feels a very interesting decision to have taken.
Yeah, we found out a few days ago only that it was going to be an interim CEO until then. I think absolutely the plan is to recruit permanently to that position, and the interim CEO has declared herself as very keen in her first briefing to staff to secure that post, and has assured everybody of their absolute commitment. But yeah, I think you're right, it's not ideal.
So I'm just picking up on your point about boroughs and some being wealthier than others and maybe funds moving around. How would we scrutinise that? I mean, obviously, Hannah, you will be batting for this borough in terms of that, but how would we as a scrutiny committee understand that and be able to scrutinise it?
There's lots of data, Anna might when we talk about this, there's lots of data at the moment actually in slides that have been coming into email boxes over the last few weeks, where the new ICB to be, it's operating as a single ICB now, but it's not formally one until the 1st of April, is starting to publish tables of the 13 boroughs and how they rate in terms of their deprivation levels and what have you. And within the boroughs, individual neighbourhoods, which we've just been talking about. And, you know, I think that definitely when money starts to become available at the ICB level, they will look for bids, proposals, they will develop criteria from neighbourhoods and places to secure some funding to do things locally. And I'm pretty sure that one of the key criteria will be to do with levels of deprivation locally. And obviously there are very significant levels of deprivation in RBKC that you would be putting forward. But I think overall, certainly the way that the ICB measures deprivation and sort of calculates league tables from that, and Anna disagrees with the way that it's done, we talked about it a lot. I'm not qualified to comment on it, but the way that the ICB has traditionally done it, you would argue doesn't reflect the local need, I think. So that's, you know, a little bit worrying, but, you know, Anna's always in there batting for RBKC about that and making the case. But, you know, as we focus more on deprivation and try to target health inequalities more, then that does bring with it a risk that those areas which being measured in a certain way, yes, are going to attract more.
Yeah. Yeah. And I guess our job going forward, that won't be necessarily a member of this committee, is how we scrutinise that and how we are on top of it.
Thank you.
Very well. No, thank you.
I was just going to ask one last question. Sorry. Just in terms of, you talk about the payer in the report, so framing the ICB's future role as a high-level strategic commissioner, and just doing sort of explain what that means in practice for borough partners.
For me, this is the ICB is the payer now in the sense that it's it takes the funding from central government, it flows into the ICB, and it sort of shares it out. I mean, there was this idea of moving away from, commissioning and contracting and the focus on that, and more towards this idea of working collaboratively and not getting into the same kind of contractual conversations that the NHS has for the last 35 years since the reforms that happened then. And I guess it's a bit of a move back to that. The strategic organisation will focus much more on the contracting side of things, and counting widgets, frankly, might be the best way of putting it, and funding volumes in hospital rather than just handing blocks of money over. It's all quite technical contractual stuff. I wouldn't waste too much time on that particular stuff.
Well, thank you very much for coming. And yes,
Thank you.
thank you. Anyone else who wants to speak, please feel free to as well. Moving on to agenda item 7, which is the work programme report. This report is an update of Select Committee's work programme for the basically year of 2025-2026. Members are invited to discuss the work programme and any emerging priorities for the last meeting of the year. Note the change of the date of the meeting and ask if you're okay with that.
Yes.
So the dates are going to change to either the 23rd or the 24th, but
Most likely the 23rd. March. Monday. Do we have enough?
we would have quorum.
We have a quorum. Are you happy for it to go ahead?
Have you said the date?
And the 23rd. I know you said you couldn't do the 24th.
Yeah.
But the most members can do the 23rd, so we'll go.
Okay, great.
It's going to be the 23rd, isn't it?
Yeah.
Yes.
My last one. This is your last one. And sorry, I haven't even finished the. I don't think we've got anything else in that section, do we?
Is there anything in November?
No.
Was there anything in November 2026?
That's not been developed yet. I don't know yet.
So the
Long way.
Okay.
Yeah.
So it's the 23rd of March, yeah?
Yes.
Yeah.
Thank you.
And just another quick point. It's always a good idea to maybe think ahead to what you want to be looking at, or
Yes.
HMRC will be looking at it in Julian's.
We're going to be making recommendations, particularly we spoke about it in OSC the other day, to the first committee that happens next year, so that it isn't a sort of stress in terms of.
Yeah.
If anyone has any, that would be helpful.
You see. I think what is important. This won't necessarily be the committee going forward, and therefore, but in addition to a list of things being on future meetings, there's some note about why we asked for them to be on future meetings and the points we wanted people to bring to those reports, because the danger is it gets lost and a new committee is starting afresh.
Exactly, and I think over the last year or so, obviously, committees built up a lot of insight, wisdom, and knowledge about health and care services, and because I'd say on.
I'm not quite sure. I haven't read the last paper whether I have any insight or knowledge. But
Well,
some insight.
I thought it was interesting. So I think that would be good to pass on to new group of members. Post night.
No, definitely. And I think if anyone else has got any points, that concludes the meeting. Thank you everyone for everything. Thank you.